Welcome to From the Front Lines, Surgeons' Voices. Today I've got the singular honor and pleasure of having two very distinguished guests from the Detroit Receiving Hospital affiliated with Wayne State University, Doctors Ann Ledgerwood and Charles Lucas, two pioneers in trauma in the U.S. Welcome to both of you.
Thank you.
Thank you.
The reason for the specific interview today is you have set the benchmark a second time. Your hospital under your leadership was the first hospital in the United States successfully surveyed and accredited by the Committee on Trauma in 1988. And now you've set a new record by being the first hospital again successfully through a virtual site visit in 2020. I'd like to speak a little bit about that virtual visit. Perhaps we could start with you, Dr. Lucas, and tell us how it evolved that you were, again, the first hospital site visited and accredited.
Well, I was at one of the meetings in Chicago with Dr. Hoyt, and it became apparent that the virus was going to be a big problem, and it was going to interfere with the site surveys by the Committee on Trauma. And Dr. Hoyt shortly thereafter came out with a notification that our visit would be in March of 2021 instead of March of 2020. And I sent a note to Dr. Hoyt suggesting that we do it virtually, since it was my opinion that we're going to be wearing a mask well into 2021, since this is going to be with us for a long time. And he was so kind to accept my suggestion that we have the opportunity to be the first hospital that is verified by a virtual technique. And he did that. And of course, that meant that Dr. Ledgerwood had a whole lot of work.
Thank you very much. It's great to have such innovative spirit in the college, as of course is one of the main assets of the college is the innovation by our fellows. So that being the case, let's turn to Dr. Ledgerwood and talk a little bit about some of the work you had to do in preparation for the survey.
Initially, we got the approval of Dr. Audrey Gregory, our CEO. That was extremely important to have supportive administration. We had a leader from the administration, an assistant director who became the lead, brought together the heads of medical records, compliance, informational technology, which was really the key person. The verification requires review of medical records. One of the college's problems or issues is how do we do that confidentially? Likewise, the hospital wants that done confidentially. That issue got solved by putting on a flash drive that was protected with a password that the reviewers were given the day of the visit, so they could open that flash drive which had been sent to them. That included not only summaries of the medical records, which we had already prepared, but also our performance improvement and systems committee meetings. The minutes of those meetings were available on that flash drive. That was a big step in order to be able to provide to the reviewers what they needed. On the day of the site visit, which was done virtual, with both reviewers being able to review medical records remotely, and also have access to our medical records so that we could actually show them a CAT scan, for example, of a patient that they might be reviewing. I think this was a crucial step. Our trauma program manager was able to put this flash drive together, including a menu for the various things on the flash drive, which was the suggestion of Dr. Lucas, so that they could at least scroll through things fairly quickly. That was a key thing, which I think was very important for us being able to do this virtually.
Well, it's very good that you had the cooperation of the C-suite of administration, because without their cooperation, of course, these things tend not to work. And it's great that they recognize the value of the program. So as you were getting ready for the site survey, you had a figure out how to get your records in a format that was HIPAA compliant, that wouldn't violate HIPAA, have things ready for the reviewers. So the medical records is one part of it. There's also the facility, and the site surveyors like to see the facility. So how did you manage to convey a showcase of the facility in a virtual visit such as what we're doing here on Zoom today?
So we had filmed on a phone a travel through the facility showing the ambulance bay, the resuscitation room, the blood bank, operating room, surgical ICU. On the day of the visit, we had two wireless on wheels. One would be stationed in the ambulance bay decontamination area, while the other one was in the resuscitation room. And then we would go from one machine to the other, so that the reviewers could talk to the personnel there and get information about that particular site.
Very interesting, very, very innovative and very interesting. Dr. Lucas, this survey occurred during COVID-19. Was there an impact of COVID-19 either on what you're doing in the trauma center overall or on the site visit?
We're one of the centers for seeing a lot of the virus, but they're separated, as you know, from the rest of the patients. And I don't think it interfered with the actual virtual tour, which was able to demonstrate to the reviewers what they want to see in the hospital.
Let me, if I might, please ask you a question that's slightly off the topic of the survey itself, but relative to Detroit being one of the initial salvo of hotspots that COVID-19 fired at us, and that is caring for the trauma patient with COVID-19. So as we've evolved to the point where testing is more widely available, are you routinely testing patients? Is there time for that in the trauma setting? Do you assume that they're all positive and treat them as such? I'm just curious surgically how they're managed.
There's a great deal of paranoia about the virus. And during the cold weather, we had our disaster tent set up in the entrance to the hospital, actually on the dock outside the hospital, so that sick people were coming in a separate entrance after they were tested in the tent. So this has been a very active activity on the part of the hospital in order to make sure that everybody is safe. Unfortunately, sometimes patients with the virus have bad injury and have to go to the operating room. So all of the paraphernalia that has to be worn in caring for the patient in the ICU has to be worn during operation on the injured patient.
Okay, thank you. That's quite helpful. Dr. Ledgerwood, if we're looking at some of the things from some of the aspects of the virtual site visit that you found helpful, some that you might do differently, what do you think are some of the good points and the points on which perhaps improvements could be made down the road?
That's a good question. One of the things that we've talked about is what happens to this flash drive after we sent it out to the reviewers. We've since learned that that's sort of fixed so they cannot copy it, or and then we're asking it to be sent back to us so that we are able to maintain our own compliance with our medical records. That has been very important with our compliance people. The most important thing, I think, is the technology people, the interventional people that helped us so much are so important to be part of that visit for the whole time that we're doing it. Also, I thought that the reviewers were separated for the chart review. They were also separated for review of documents, and I would have liked to have been able to participate with both reviewers. And as a trauma medical director, I had to pick one room over the other. So what I think would be better to have those sessions together. The other thing was the virtual tour. And it's very difficult to do that without patients or people getting in the way of being able to talk to just the people you wanted to talk to. So there's always the possibility to be able to film at some early hour morning when no one's around the travel places, and then simply interview in a room the nursing personnel that would belong to each of those areas. I thought that might be a bit helpful.
Interesting. A bit like when Hollywood is filming in the middle of a busy city and they do it at 2 in the morning with all the floodlights, so there's not as many cars on the street.
Exactly.
Now they're in trauma center, I guess 2 in the morning, maybe your peak hour, I'm not sure. Now, another question, Dr. Lucas, relates to some of this virtual conferencing as we're doing. Certainly within the programs of the Commission on Cancer, within the National Accreditation Program for Breast Centers, within the National Accreditation Program for Rectal Cancer, we've gone to doing all of our multidisciplinary conferences now by these type of platforms. So we practice physical distancing. Is there an equivalent in the trauma programs where you have some conferences that would have been in person and now you're doing them in a virtual manner?
I believe that Dr. Hoyt opened up the door, and this virtual technique is probably going to be applied for 90% of the trauma center visits in the future. And I think it'll also be applied after everybody gets used to it, to the cancer program, the colon and rectal program, the urban hospital program. This is just going to take off as we get more and more proficient, because it doesn't make a lot of sense for the hospital to be paying for travel time, to be paying for hotel time, if you can achieve the same thing on a virtual visit. I think this is going to just take right off.
The other aspect of the conferences, of course, is the educational component, where you're with other faculty, with residents, fellows, medical students, and whereas it used to be some large number of people in a room with coffee and donuts or bagels or something, or sandwiches, depending on the time of day. Now, instead, it's as we're doing. And have you adopted that in the trauma program for education as well?
Our grand rounds are done that way, and our morbidity and mortality meeting for the residents are done that way. We are still holding our own trauma, morbidity, mortality, and trauma systems meetings with people wearing the mask and social distancing, but we have really a small enough group we can do that. The American Association for the Surgery of Trauma is going to be meeting virtually. I think almost all of our educational meetings are going to be virtual. Dr. Lucas asked the other day when he thinks we might be able to go to a meeting again. I'm not sure.
I don't think any of us are sure. It keeps getting pushed back. I've gotten some notifications for the first half of 2021 already that things are either being postponed, canceled, or going virtual.
One of the things I think is important is that the hospitals do get their site visits. The trauma program requires the re-verification visit every 3 years. There's been talk of, is that really necessary? I am a strong believer that it is necessary. And, already we're delaying everything a year. So I really think this is important that we develop the techniques and use the techniques to do the site visits, so hospitals are not left with 4 and 5 years between their verification visits.
Excellent point. Thank you very much. Well, in deference and respect to what you've done for trauma in the United States and globally, I'd be remiss not to ask if you have any other comments you'd like to make before we wrap up. I'd perhaps start with you, Dr. Lucas.
Well, I think the two of us have been very lucky to have been associated with the college and be involved with the college, not only in trauma, but with all of the other things that the college does. And as Dr. Ledgerwood said, whether it's cancer, trauma, whatever, you need to have frequent visits of hospitals, because in 3 years, there can be a whole lot of things that change. And so you got to really continue to have the 3-year thing, which will be excellently carried out with the virtual site visits.
Thank you. Dr. Ledgerwood?
I certainly agree. For example, we were able to implement several things in our hospital just because we're going to have a virtual site visit, just because we were going to have a site visit. And we wouldn't have been able to get those things had we not been going to have a site visit when we were due in March. And so I'm a firm believer that the verification really assists us in having what we need to take care of the patients.
Thank you both very much for your time, your insights and reflections, and thanks you for all of you that you've done for the American College of Surgeons, for surgeons, and in particular for trauma patients around the world. Much appreciated.
Thank you very much.
Thank you.